Okay, in our last section of lecture, I want to talk about the phenomenon of small area variations. What are small area variations? Well, let's back up. Some of you may have read, I hope all of you have read, Atul Gawande's article, Cost Conundrum, which appeared in a 2009 issue of The New Yorker. And this is a really famous article in which he compared the town of McAllen, Texas, which is at the very bottom left of Texas on the Mexican border. I can pull it up here. McAllen, Texas is down here, and he compared McAllen to El Paso, which is over here. Hopefully you can see my cursor. And what he wrote about is that McAllen residents have 50% more specialist visits when they're critically ill, 60% more cardiac stress tests, twice as many bypass operations, 3 times as many nerve conduction studies, and 6 times as many home health visits. Now, why would we see such large differences in per capita utilization rates between those two towns? The phenomenon of small area variations, which is basically what this kind of micro example is illustrating, small area variations have been documented by almost a limitless number of studies worldwide. And in addition, an extensive body of literature has suggested that selected medical services are basically overutilized. The estimates, I think, regarding the proportion of inappropriate medical care given range from 15 to 30%, with a number of more recent studies putting it at about 4%, so much lower. But as a result of these studies, as a result of this conversation and of these articles, the public has become really fond of blaming high medical costs on physicians who prescribe needless medical care or perform unnecessary surgery. Now, in contrast to the supplier-induced demand theory, many have argued that small area variations in care are actually related to physician uncertainty with respect to diagnosis and treatment. Some people also use the physician practice hypothesis, which basically contends that per capita variations in the use of medical care, particularly surgery, reflect, I think, systematic differences in, let's call them clinical opinions regarding what's the appropriate amount and what's the appropriate type of medical care. And those subjective differences are collectively referred to as quote unquote practice style, and exist primarily because of the uncertainty surrounding the practice of medicine. So the study of small area variations originated with a physician named Jack Wenberg from Dartmouth University. And he's really the pioneer in analyzing all of these wide variations of practice patterns, not just between McAllen and El Paso, but all across the nation. And the sources of these variations have really been the target of a lot of research. It's important to note that they are far from understood, and they are also the focus of a lot of controversy. So Wenberg's seminal article appeared in Health Affairs in 1984. I'm going to show you a graph in a second. And he set up what's now called the Dartmouth Institute, at Dartmouth, obviously. So this graph is from his 1984 paper. And this exhibit on the left is a lot of information on this slide, but bear with me. This exhibit is showing, maybe I'll get my laser out. Oh, I can change the color too. Huh, nope, can't change the color. So this exhibit shows geez, the relative variation of rates for cases classified by cause of admission using a modification of the DRG case mix classification system. So that's a lot of jargon. Each dot here represents either a hospital or a hospital referral region in Maine. I'm going to take a stab and say these are regions. And each column is a different DRG related admission. So here, these dots represent hospital markets and the number of admissions for hernia repairs per 10,000 person years. These are all age adjusted. And some of these DRG dots look compact, and some of them have quite a bit of dispersion, right? So those of you with some medical knowledge in looking at this can probably recognize an association between the order of the listing of DRGs here. We have hernia repair, acute myocardial infarction, heart attack, hysterectomy, chronic lung disorders, tonsillectomy. And they basically are ranked from the measure of variation in rate of admission and the degree of discretion that physicians can exercise in the decision to hospitalize or not. So you've got, these are low on the scale of variation to very high on the scale of variation. At the lower end of the variation scale, we see admissions for hip fracture, for myocardial infarction. For these conditions, there's really very little choice. And under current standards of care, patients really have to be hospitalized. But in the high range of variation over here, those causes of admission that are more variable than, let's say, hysterectomy, so things like tonsillectomy, the situation's not so clear-cut. So, for example, many cases of bronchitis or fracture of the forearm can be and often are treated in the ambulatory setting, not in hospitalization. So it's, some people speculate that the dispersion that you see on the right-hand side of this graphic reflects differences in local practice styles in how the decision is made to hospitalize. For the examples of causes of admission that rate at the extreme high end of the variation scale, I think the data speak for themselves. You can really see that per 10,000 person years, there's a lot of variation in whether or not hospitals within these markets are admitting people into the hospital versus, for a heart attack, almost everyone is hospitalized around the same rate, or at least less variation here. So the researchers at the Dartmouth Institute, so that's the institute that Winberg set up, have produced what's called the Dartmouth Atlas of Healthcare. And hopefully you all have been exposed to this in your health policy classes at some point. Basically, the Dartmouth Atlas is a geography of resource distribution and also utilization for the US. The Atlas basically shows that the amount of medical care consumed by Americans is highly dependent on where you live. Again, I really suggest you read or reread the Gawande article in the New Yorker. This is an example of an atlas map. So these, each, area here is a hospital referral region. I don't remember the exact number. I want to say there's something like 300 on this map. And here's an example of one such map. So this map of hospital referral regions is showing the average number of inpatient days per Medicare beneficiary. So you can see even within Texas, I'm assuming these are adjusted for gender and age, so forth. But even within Texas, you can see that there's a large variation in the average number of days that a Medicare beneficiary is staying in the hospital. Same with, California has quite a bit of variation, certainly Florida, Jersey has some, New York. There's tons of these graphs on the Atlas webpage if you want to geek out over them. This is another way, I think, of looking at the data. It's another dispersion type graph. So it's a ratio of surgical procedures relative to the national average for various hospital referral regions. So again, you're looking at kind of less dispersion and higher dispersion based on the degree of discretion that any one physician can have in deciding whether or not to admit. One thing I find very interesting is if you look at the variability in the rates of hospitalization, more than half of that variation can actually be explained by differences in the local supply of hospital beds. So that could be a few things. That could be, one, maybe some hospitals have better predictive models, or if you're a little more cynical, maybe if you have the beds, you're just filling them, right? I'll leave it up to you to decide. So why do we see small area variations? Well, in Wenberg's own words, there's kind of two different hypotheses here. The first, he says, one reason for the variation is that professional controversies that arise because of ambiguous or incomplete scientific evidence on the value of specific services. So he's saying that medical guidelines just may not be very clear, or they could vary. There could be some uncertainty as to best practices. Now, a second reason, in his words, for the variation phenomenon is the individualistic practice styles adopted by physicians. This could be for reasons of their own or of their patient's convenience, or their interpretation of the requirements for quote unquote defensive medicine. So despite the large number of studies on this physician practice hypothesis, it's, again, like many things, difficult to determine empirically the extent to which physician practice style explains geographic variations in the utilization of medical services. And if that's something you're interested in understanding, why I keep saying why all of these things are difficult to determine empirically, I highly suggest you take an econometrics course, or maybe even a causal inference course. Because physician practice style is difficult to measure, especially at the aggregate level, its impact on the amount and type of medical care consumed is ultimately difficult to judge. I think there's certainly no doubt that the presence of uncertainty means that individual physicians will follow different courses of action when they treat patients. But insofar as clinical decisions are ultimately based on subjective factors, physician practice style is obviously likely to influence medical care. One point I just made about defensive medicine potentially explaining these small variations. A time permitting in class on Wednesday, we're going to talk about medical malpractice, which I think will kind of tie together nicely both issues of supplier-induced demand and small area variations. So with that, I'll leave you with the final practice questions for the evening. You can press pause here, and I look forward to seeing all your faces on Zoom this week. Take care.